Okay, we'll go ahead and get started. Hello, my name is Susie Wolf. I'm a faculty member with the Physician Assistant Program in one of the Graduate Health Professions programs at Wingate University. I am so excited to be here with you guys today and presenting with Dr. Laura Happy. And just a little bit about myself, as I mentioned, faculty member with the PA program, currently working towards my doctorate of health sciences and teaching a course in the PA program right now that's focused on research epidemiology and statistics. And we're excited to be here with you today.
And hi guys, welcome to our Lyceum today. We're glad to have you. My name is Laura Happy and I'll be co-presenting with Susie today. And as she mentioned, I'm a faculty member in the School of Pharmacy at Wingate, pharmacist by training. I also have a master's degree in public health with an emphasis in epidemiology. This is our second Lyceum that is on this topic. We did a similar presentation a couple of weeks ago. And, we're just kind of curious as we're getting started here. One thing that we're going to do in the presentation is we're going to ask you guys some questions as we go through. And so we just want to ask you guys to use the chat function to respond to our questions. So we're curious if anybody attended our prior presentation where we talked about epidemiologic modeling for COVID-19. So if you did, if you would just put a comment in the chat box so we know. We just want to kind of tailor the presentation towards our audience today.
Okay, it looks like we have a few people who attended. Perfect. We're so glad that you guys came back for a second round. And so just a brief recap on the previous Lyceum that we gave, we really talked about some general epidemiology terms. We talked about epidemiology being the study of distribution and determinants associated with a disease. We also talked about some of the general concepts behind epidemiologic simulation modeling and how the outcomes, projections of those models really are dependent on the assumptions that are put into those models. And so we, of course, looked at some of the epidemiologic simulation modeling associated with COVID-19 at that time, but that was approximately 2 weeks ago. And so things have changed since then, and we're excited to speak with you today and update you on some of those things that have changed associated with those models. So today, we're going to be looking to further define what exactly epidemiologic simulation modeling is as it relates to COVID-19. And we also want to have a discussion as to possibly how the timeline for COVID-19 and some of the restrictions and recommendations associated with social distancing have changed secondary to these models changing over time. And lastly, we want to focus on the importance and the role of social distancing, of course, with the pandemic, but also with ourselves and here in North Carolina.
As Susie kind of teed this up, a lot of what we're going to be talking about today has to do with timelines and how things are changing. Hopefully we won't be too duplicative for those of you who heard from us last time, but we'll try to catch up to folks who didn't hear that prior Lyceum. But we really just kind of wanted to start with this quote from Dr. Fauci. I'm sure you guys have all seen him on the news. So he is the head of the National Institute of Allergy and Infectious Disease, and he's on the White House task force for COVID-19. And this quote really just kind of sums things up. He says that we don't make the timeline, the virus makes the timeline. So we're going to be talking through some of the changes that have taken place recently and what we kind of see coming down the road. But, I think some of the burning questions on everyone's mind are when will these restrictions be lifted? What's going to be happening in the future? And frankly, there's just a lot of unknowns. And we're not really in charge. The virus is in charge. So just to kind of recap a little bit, and like I said, we're going to spend a few minutes just recapping what we talked about last time, just to catch everybody up. But I wanted to just start here with this flattening the curve graphic. And I'm sure all of you guys have seen this, you've heard this language. This is basically the mantra for how we get through COVID-19. And we're going to kind of unpack this today and then get to a lot more sophisticated models that have been coming out over time. But this is kind of the basic model. And just a epidemiologic simulation model is a tool that we go through when we need to predict or forecast some results that we don't really know for sure what's going to happen. We use mathematic equations and sophisticated software programs to create these models. Models like this, forecasting models, we use them in a range of disciplines, in engineering, astrophysics, medicine, financial markets, a lot of different disciplines. And so this is really just applying this to epidemiology, or the distribution and determinants of disease. Anytime that you create a forecasting model like this, there's a lot of unknowns. So when we're putting together these mathematical equations, we have to put in inputs, and those inputs are going to be based on assumptions, and we learn more about those assumptions over time. And that's what you're going to kind of see today as we talk through this, is we're learning more about the disease, we're learning more about the virus, and therefore those assumptions or those inputs that we put into the model are changing. Therefore the models are changing. Doesn't mean that the models that we looked at 2 weeks ago were bad. It just, in fact, a good modeler is always updating their model as we learn more. So that's what you're going to see today. And of course, it's very relevant with COVID, since we don't know a lot about COVID. But the basics of the flattening the curve, just to make sure we're kind of all on the same page, is, the key parts of this graphic are the capacity of the healthcare system. So if we did nothing, we have this peak of diseases that exceed the capacity of the healthcare system, which creates a big problem, right? Nobody wants to be working in a hospital and have too few ventilators for people that need it to save their lives, and have to make that decision on who gets a vent and who doesn't. So the idea is that we flatten this peak out to look like this blue curve, so that we stay within the effect of our healthcare system. There's a quote that I've heard that I like, that depicts this very well. It says, it goes like this: what if you were about to face your worst enemy, of which you knew very little, and you had two options? You either run towards it, or you escape to buy yourself some time to prepare. Which would you choose? And that's really kind of the rationale for flattening the curve. So we're trying to buy ourselves time to prepare, to ramp up the healthcare system for this disease. So we're going to walk through a timeline quickly here to kind of back in the middle of March to where we are today. So the model that we went over last week, and really the model that we believe kind of was the big impetus behind the Trump administration coming out with their original policy, which was the 15 days to slow the spread. This came out in mid-March. So I'm going to walk through briefly this Imperial College model. So Imperial College is a very respected institution in the United Kingdom. It's equivalent of the Ivy League colleges here in the US. And they created an epidemiologic simulation model. And I'm going to walk through the inputs and assumptions that they used at a really high level, but we're not going to do this for each of the subsequent models that we're going to go over today. We're going to go over, I guess, maybe 3 additional models today. But I just want to kind of explain this to you so you kind of have an idea what those inputs and assumptions are that might go into an example of one of these models. So the Imperial College did the model. They created it both for the UK and the US. They input data around the size of the population, the age distribution of the population, where the people live in the population, who's going to school, who's going to work, what the average class size is, what the average workspace is, so that they know kind of how frequently people are interacting with one another, which would give the opportunity to transmit the disease. Now, they actually didn't create this model specifically for COVID-19. They had created the model previously to project what a pandemic of influenza might look like. So they were actually able just to update that model, change the assumptions to make it fit the COVID-19 virus. So this is something that already existed. So in addition to looking at the populations, then they had to kind of figure out how the disease would transmit through the population. So next on the screen, you'll see some data around the virus transmission. So they had to assume what is the incubation period for the virus, and they assumed 5.1 days. And then how long is a person infectious? So from what point, once they have symptoms, how far before they got those symptoms were they infectious, and then how far after. And then for each person that gets the disease, how many other people do they infect? And the statistics for COVID-19 is somewhere around 2.4 is the average number of people that one infected person will infect. Relative to flu is about in the lower ones, 1.1 to 1.3. So it is a more infectious disease than the flu based on the spread. And then you can also see here the inputs that they used for the percentage of cases that required hospitalizations, that required critical care, and then the percentage of cases that ultimately died. And those are stratified by age groups. And as I know you can imagine just by watching the news, we're learning more about this, unfortunately on a daily basis as we can add data to this table and get more precise estimates. So what were the results of the Imperial College model? Well, they looked at effectively two things. They looked at, okay, first, if we were to do nothing, and then what would happen if we implemented these suppression strategies. And again, I think this is really what spurred the US to implement some of these big policies. So on the left-hand side of the screen, if we did nothing, I just want to orient you to the graph. This is the deaths per day per 100,000 population for GB, which they're using that for Great Britain, and the US. And so if you look, the US is the blue bar, and remember this is normalized per day. So if you look at the actual key in the graph, you can see the projected deaths in the US if we did nothing was going to be 2.2 million. In Great Britain, it was going to be 500,000. The peak per day would be higher in Great Britain just because of the population concentration. But I think this number of 2.2 million, if we did nothing, that was really scary. And that's really what spurred us to take some action in this country. So next they modeled out what would happen if we did these suppression strategies. So this is kind of the graph, I think, that started the mantra in the US of flattening the curve. So it's a timeline here, and then the y-axis is the critical care beds that were needed. So if we did nothing, you have this big peak. And then this is the red line here. This is the number of critical care beds that we currently have. So obviously we would have way exceeded it. This blue area is the time frame in which we would do those suppression strategies. So you'll notice that this goes from April to September, which is not what we have in place right now. But there's a combination. The green line and the mustard colored line are the suppression strategies. So if we implement those, we flatten that black curve down to here and we stay below our bed capacity. So then we don't get into that situation where we're having to pick and choose who gets a vent and who doesn't. What then happens out here is after we lift that policy, we get what we call a second wave. And we're going to talk a little bit more about those second waves during our comments today. But these were the results of the Imperial College model, again, that initially kind of spurred the 15-day plan to slow the spread of the virus. So then after that, fairly quickly thereafter, a couple of additional models came out, and we're going to talk about some of those models. And the first one we're going to talk about is actually we're going to talk about this one first, the University of Washington, and next we'll talk about Harvard, just kind of from a logistic, what makes sense rather than a timeline of the specific days that they were released. But this University of Washington model has gotten a lot of attention and press in the last couple of days. And this is really kind of an interesting case study because it helps us explain the differences as the researchers have gained more information and the drastic changes that have been made. So the headline that you may have seen is that the number of deaths in the US between now and the 1st of August has been projected deaths. The number of projected deaths has reduced from around 83,000 to around 60,000. So that's the headline that's been over the news in the past 24 to 48 hours. So we're going to unpack that. So this comes actually from the Institute for Health Metrics and Evaluation. It's IHME. And that is a company that is housed within the University of Washington. So I'm just kind of calling it the University of Washington model. So these are researchers from the University of Washington. And as you can imagine, you probably heard, that was the first outbreak in the US was in Seattle. So this team has been tracking this closely. And this group does a lot of this type of simulation model. They're not new to this with COVID. And I'd encourage you to look at their website, and you can look at these models. But what we're doing here is we're going to look at their April 2nd release and then their April 7th release and kind of compare and contrast and see the differences on what they've been projecting. And we'll talk about what they learned and why those estimates have changed. So this is hospital resource use, and this is for the US. And if you go to this website, you can look at this per state, and you can also look at different countries. But what they project is, when is the peak hospital resource use going to happen? So for example, in their April 2nd model, they were projecting that was going to happen on April 15th. In their more recent update, they're expecting that to happen sooner, on April 11th. They also project the number of hospital beds that will be needed, the number of ICU beds that will be needed, and the number of ventilators that will be needed. And all of those estimates have gone down. And I know that it's difficult to see on this slide. I'm going to show you in a couple slides a table that will be easier to interpret. But all of those numbers have gone down. So the other big graphic that the University of Washington model puts out is the total number of deaths. And this is that headline that I referenced. So in their April 2nd release, they were projecting about 84,000 deaths. And now they're projecting about 60,000 deaths by August 4th, and that's in the first wave. So if you remember back on the previous slide, I talked about that second wave. So this is in the first wave. So big change here in the number of deaths. Here's the website here too. I wanted to make sure I pointed that out to you guys. You can look up healthdata.org, and it'll be easy for you to find the COVID model. But this is the table that I was referencing that kind of shows you between the April 2nd and April 7th what those changes were. So the hospital bed needs at peak have decreased by about 60%. Projected ICU beds that we'll need at the peak have reduced by 41%. Kind of same story with ventilators. The peak death rate for daily deaths is also 4 days earlier. So it's April 12th, so just in a couple of days here. The peak number of deaths has decreased by about 16%, and then the cumulative number of deaths through the first wave has decreased by about a third. So what is it that we can attribute these fairly sizable changes to? Again, I want to just reiterate, this doesn't mean that the first version of the model was bad. What it means is that these researchers have done a good job, and they've gotten more data, and they've been able to make more precise and more accurate projections. So I'm going to walk you through 3 of the assumptions that they have modified to make more precise projections. So the first big change or refinement to the model that they made was looking at what was the estimation between the time of implementation of social distancing policies to the peak number of daily deaths. When they first made the model, they only had one country to work from to come up with that time frame. Now they have multiple countries to work from to come up with that time frame. I think they had somewhere between 5 and 10 countries to input that data. So they have a much more precise estimate to project the time between the implementation of the policies and the peak number of deaths. Next, so this newer version incorporates differences in community by community suppression measures, rather than the earlier model, which sort of just applied an average of the social distancing policies across the country. So as you know, in different communities, different counties, different states, we have different social distancing policies. And so before they were just kind of having to make some assumptions. Now they've got a lot more state and specific community specific data to input into their model. So again, more specific. And then lastly, they have better data on the hospital capacity and hospital hospitalizations, hospital utilizations at a state level. So, you know, in the prior version, they were having to kind of make some assumptions, but now they've gotten that state specific data on the number of hospital beds in each of the states, as well as what their current capacity is and how many people they have hospitalized for COVID. So they're precise, their measurements are just getting precise, more precise. So it's actually really neat because you can kind of see this happening in real time, and their estimates becoming increasingly accurate.
I'll just add a note to that, Laura. I watched an interview with Dr. Fauci this morning, and he again really stressed the point that these changes are a good thing. These changes are based off increased data that we're now being much more transparent and collected, and that this is why these outcomes and projections are changing the way that they are.
Yeah, thank you for that. So next we're going to look at the Harvard model. So this actually came out a few days before the University of Washington published their model online. I have seen a lot less attention paid to the Harvard model in the media, and I suspect it's probably because we don't quite know what to do with it, and it's a little bit probably more intimidating. I might use the word scary. It's a little bit more concerning. So here's what the researchers from Harvard did. So they modeled out different lengths of time for social isolation. So if you remember the Imperial College model, they looked at from April to September, and that they used that strategy to flatten the curve. But again, nobody's talking about April to September. They just kind of used that to say, okay, we need to flatten the curve. So if you look here at this chart here, they looked at different time frames. So again, this blue line, this is when the suppression strategies or social distancing strategies were in place. The negative thing about this is you still see a big peak after every one once those suppression strategies are lifted. And similar in this graph, we've got this bar here, which shows the capacity of the hospital system. And so in these simulations, A through D that I'm showing on the screen, we haven't built up the capacity of the hospital system at all. The other thing that they did in the Harvard model is that they assumed that there's some seasonality to the disease. We don't know yet what the seasonality is going to be for COVID-19. We don't know if it's going to look like influenza, which of course is seasonal, or not. But there's a possibility that it will be seasonal. So when they incorporated these two things, they kind of came up with the same conclusion, where it really just doesn't work, because no matter what happens when we lift those social distancing policies, we still come up with this peak that exceeds our bed capacity. So really pretty concerning. And just because we haven't talked about this yet, why is that we're coming up with these peaks after we lift the social distancing policies? Well, the reason is that we're not creating any population level or herd immunity. So the virus really isn't out circulating in the population. So once we all start circulating again, it will start to circulate, and we haven't generated any immunity to that, and it will start to cause disease again. So this is the next kind of thing that Harvard did, which I think, sorry, I'm putting it on top of my screen there. Okay, this is the next thing that Harvard did that I think is kind of interesting, and I think this is probably the one that I'm not sure we know quite what to do with this, and maybe why we're not seeing this covered on the news, but let me talk you through this. So basically what Harvard said was because there's about a 3-week lag time between the start of social distancing and the peak demand in critical care, give or take, about a 3-week lag time. They said, well, what if we did sort of pulse social distancing? So we did it for a while and then we lifted it, and then we did it for a while and then we lifted it. So that may allow our hospital system to absorb the burden that would result, and it would also allow for some herd immunity to take place. So if you look at this graph, these blue lines, again, this is where those social distancing policies are taking place. So these, you can see they kind of reflect the pulses. So in contrast to the prior screen where there was just one big blue area, now it's like, okay, we do social distancing, then we take a break. We do social distancing, and then we take a break. So that's what this next set of modeling that Harvard did looks at. And they're also still considering seasonality. In the first graph here that I'm showing, graph B, it doesn't work because we still continue to exceed our hospital beds. In the second graph, what they're projecting is if we actually increased our hospital bed capacity, and it's a little bit tricky here because they changed the y-axis for you to see that, but if we actually increase our critical care bed capacity, then this starts to work, and then we can taper off, and you can see that the disease stays below the line here, okay? So this is the scenario in which the disease stays below the line. If we have the social distancing pulses, if there's seasonality to it, and if we build up the infrastructure of the healthcare system. In this prior model, unfortunately, it has us doing social distancing all the way out until April of 2022 for us to stay below capacity. So as I said, this is probably one of the reasons that this model isn't being touted in the media, is because it doesn't paint a very friendly picture. So these were some of the key, probably the key models that have been released in the US. And then just as we were approaching the 15-day mark from the president's original policy with the 15 days to spread the slow of the disease, that's when he went ahead and extended the guidelines through April 30th. So you can see how these models probably influenced some of the decisions that were made at a national level. So now we're going to try to kind of bring it home, and Susie's going to talk about what we're seeing at the local North Carolina level.
That's right. So we want to really kind of bring it back to our local community and our state here in North Carolina, and trying to gain an appreciation for the perspective on the pandemic here locally, and also, you know, how people are perceiving social distancing restrictions and if they really feel like they understand them and what their effect may be. So we have a clip here, and this is a clip from the Charlotte Observer, which was released on March 30th. And this particular clip, it really does a great job of showing you guys some of the different perspectives that young people, middle-aged people are having in regards to social distancing and the effects of COVID-19 in Charlotte. So we're going to go ahead and play that.
It's pretty scary, I'll be honest. I am part of that population that is nervous about it, kind of looking at cases throughout the country every day for new information about how it's spreading and where it's spreading. And so, yeah, definitely nervous about it.
Actually, I was most worried for the elderly and people with immune compromise. But now, I think honestly, where I am in life, I'm most worried about the economy and the impact it's going to have on all of us. I'm still worried about deaths, but I'm healthy. My kids are, young adults. I'm also a little concerned because my daughter lives in Denver, and now I don't think she'll be able to come home to us.
My age group, not to sound like ignorant, I guess, but doesn't really seem to be affected. So I'm not worried about it for me personally, but I guess I know that it does or is supposed to affect like a larger amount of the population who is older. So I guess just kind of like worrying about those kinds of people and trying not to like go out in big groups or do things that could make me like a vector for passing that on to somebody.
We moved here in November, and unfortunately it's, you know, in the 20s in Minnesota, and so a lot of our family and friends are stuck inside during this time. And although we have been inside the past few days as much as possible, we just couldn't help but kind of get out into this weather and kind of help our spirits a little bit.
I kind of stayed inside and was just going to I was still going to the grocery store, but then I'd stay inside. And I think I was watching too much of the news, and sometimes it can be daunting. So to get out on this beautiful day, it was wonderful.
It's kind of crazy, honestly, that so many people are out, and myself being one of them, obviously. But I came here and I wasn't really expecting like such large groups to be gathering. But I think everybody's kind of like doing their own thing and just enjoying the weather. It's beautiful out and it looks really nice. So
stressful, but I don't know. I think with the weather being nice, I think that's kind of helped a little bit. I'm a firm believer in Jesus Christ, so I'm wanting to be cautious, and smart, but I'm also not fearful. I'm just not a fearful person. I believe he's gonna take care of us.
Okay. So I'm sure many of you may have similar thoughts about social distancing based off of the individuals that were interviewed in that clip. So we have a question for you guys, and we'd like to kind of take a poll here. Just as a reminder that North Carolina, the state's current recommendations are a stay-at-home order through April 29th. And of course, no gatherings greater than 10 people. So with that in mind, how hard has it been for you to maintain North Carolina's social distancing policies? And we'd ask you to just go ahead and put your number in the group chat. So we have 1 as being very easy, 2 pretty easy, 3 neither easy nor hard, 4 pretty hard, and 5 very hard. I see a lot of 1s and 2s. Some 3s. All right, so I'd say overall, pretty much either pretty easy or neither easy hard for most individuals attending the Lyceum today. And so what we want to do is we want to better understand, okay, so why is social distancing important? Not only nationally, but here at home in North Carolina, of course, the Mecklenburg Union County areas. So what we're going to talk about now is a new brief came out, and this was a briefing which was developed by a group of informal, independent, North Carolina specific epidemiologists, and they were individuals representing organizations such as the Research Triangle Institute, Duke University, UNC Chapel Hill, Blue Cross Blue Shield, North Carolina, and then also Novi Psi. So there was a number of individuals who contributed to this briefing that I'm going to be reviewing with you guys. And this is as of data which was available through April 4th. And so what they really looked at, okay, what are the implications of social distancing on North Carolina's healthcare system and capacity? And they more specifically, based off of 3 individual models, they looked at 3 individual models, and then they combined those results into a composite type of result, looking at 2 different scenarios. They looked at a scenario where you would maintain the current level of social distancing with the assumption of it being as effective of keeping down low levels of disease transmission through June 1st, 2020. That's how far their model went. Opposed to lifting them, the second scenario, lifting all social distancing restrictions at the end of April. And they wanted to see what did those scenarios play out in regards to capacity for the North Carolina healthcare system. And so we're going to look at some graphs specifically related to that question. And so what we see here in Exhibit 1 on the left-hand side of the screen this is with them looking specifically at acute care beds in the North Carolina hospital system. And so acute care is going to be acute medical care with a short-term time frame that would be typically in an inpatient hospital setting. And so you can see here, this is through April 1st through June 1st, 2020. And then on the y-axis, they have the probability of exceeding that capacity of acute care beds in North Carolina. And you can see we do a pretty good job of maintaining a decent level of capacity through the middle part of April. And then because of the natural progression of COVID-19, they do suspect that approximately there's a 10% probability that we potentially could exceed acute care bed capacity in North Carolina. And then they looked at those two scenarios. They looked at maintaining current levels of social distancing like we're doing now through June 1st, and those effects on acute care bed capacity in North Carolina, which we see being highlighted by the blue line. And we can see that that only had about a 20% probability of exceeding acute care beds in North Carolina. And then they looked at the red line, which is lifting those social distancing measures at the end of April. And that's where we see that divergence. We can see that there's approximately a 50% chance that we will exceed acute care beds in North Carolina based off of lifting those restrictions at the end of April. And based on this model, they project that the peak for COVID-19 case capacity on the healthcare system will be mid to late May in North Carolina. In Exhibit 2, the graph on the right-hand side of the screen, we can see a very similar type of display. But what we're looking at here specifically are those ICU beds, so intensive care unit beds. And that's going to be a step up in care from acute care beds. So those are going to be the patients that you would envision needing ventilation, more intensive type of care and support. And so there was a very similar type of divergence as we saw in acute care, but it actually was a little bit more pronounced and aggressive in regards to exceeding that ICU bed capacity for the two different scenarios. And so what the authors or the epidemiologists who put this brief together, they basically came up with the assumption that there's two ways that we can handle COVID-19 in North Carolina: social distancing measures, and then also increasing our healthcare capacity. And they really felt like through June 1st, the best way to not overload the system was to have both of those measures in place. Now, they didn't specifically say or make a recommendation to policymakers in North Carolina, but they did stress that, based off of the model, those would be the best ways to help alleviate stress on the healthcare system. And of course, policymakers have a very unique position and challenging position that they're in, because they have to think about all of the different aspects that go into play with social distancing. Of course, people's well-being, the economy, jobs, and then also disease transmission capacity of the healthcare system. And what the authors or the epidemiologists also said in this briefing was that essentially social distancing policies are only as effective as the community that supports them in decreasing the transmission rates of a disease. And we know that Dr. Mandy Cohen, who is our Governor Cooper's Secretary of Health and Human Services, they've really stressed that we need to do a better job with this, that we really need to comply with social distancing so that we don't spread COVID-19 here in the state and cause an overcapacity issue. And so we hope that helps you guys understand if you didn't understand, but I'm sure you had some good level of understanding of the importance of social distancing, but more so on a local and state perspective why that's important for us. Because I know we haven't necessarily seen the same type of effects as New York City and some other areas that have much larger case numbers. So with that in mind, we'd like to open it up for another type of interactive question. What's your why for complying with social distancing? And you can put this into the chat. It could be, to keep yourself safe. It could be for somebody else, but what's your why? Why do you feel like it's important to comply with social distancing? We see a lot of keep family safe, a family member's health issues. Yeah, I think that one of the most important things here is empathy for others, and really trying to keep other patient populations that are at a higher risk of contracting COVID-19 and having adverse outcomes safe by not trying to spread the disease around with being out and about.
Yeah, Susie, I'll say I appreciate all these comments in the comment box. I think they're all kind of in the same vein. I have a 10-year-old and a 13-year-old. And so for us, in addition to all the great reasons that people are stating, you know, it's this opportunity to teach our kids that our actions impact other people, and we can make decisions that sometimes are, you know, not the decision I'd like to make for myself, you know, but I'm doing it for the benefit of someone else. And so we're able to model that for our kids. And I think that's really important as we're trying to teach them to be good members of communities and society.
And I'll add to that, I think that some, you know, personal silver lining perspective that I've gained from this experience, I'm just really in awe of the community's ability to comply and work together and support. And even despite it having adverse effects on, you know, economic situations, financial situations, well-being of not being able to go out of the house, it's pretty amazing how the country has united to try and comply to these recommendations. And, you know, we don't have the answers to what the future is going to look like and what these recommendations are going to look like, but we hope that we helped you understand why the recommendations may be and that they may be in the future.
Yeah, and we'd be happy to take any questions now, either through the chat box, or if you want to take yourself off mute, feel free to do that. While you guys are thinking about questions, just a couple of more things around what's going on in Mecklenburg County. And I know some of you may live in Union County or other counties, but there was a briefing last night around Charlotte, Mecklenburg County, and as Susie pointed out, the peak for Mecklenburg County is expected in early to mid-May, which is later than the data that I showed you, you know, for the rest of the country. So there's still time that's going to be happening here more locally. Also, they reported that they closed the parks to vehicle traffic, which I think kind of ties into the video that we shared with you guys, where there's a lot of people out and about, which is certainly important and encouraged related to mental health. You know, exercise and being in nature is so important for mental health, and we encourage you guys to do that. But you have to maintain your social distancing while you're doing that, which is, I think, why they restricted vehicles in the parks, because it was just getting to be too much. And they also made the comment, the city government made the comment, or the county government, that if this new measure of restricting vehicles doesn't work, then they might actually have to close the green spaces and the trails to people as well. So I think that they're trying to make changes there. Or they're trying to, I guess, encourage people to practice good social distancing so they don't have to make those changes. Another thing that they reported was, you guys may have seen this, that they were looking at turning some of the dorms at UNC Charlotte into hospital beds to help take the burden off the system. At the time they were doing that, they were expecting about a shortage of 3,000 hospital beds, which is what led them to look at a big facility like UNC Charlotte. Now they're only expecting a shortage of about 600. So it seems like they're turning their sights towards perhaps other locations in the metro area instead of UNC Charlotte that would be smaller, that could help with that capacity. So I think that's some good news. Yeah, so those were just some other local comments I wanted to share. What questions do you guys have for us? Well, if you guys don't have any questions, we can wrap up. Susie, do you have the attendance for this? That just escaped my mind until just now.
Antonio said that he's going to share it with everybody. Let me see if Antonio, are you going to do that now via chat or email? So Antonio, Mr. Jefferson, he just shared the link in the chat for everybody. If you could please complete that evaluation form, it's a way for us to be able to make sure that you get your attendance. And of course, we love the feedback, you know, in regards to the Lyceum. So please just take note in the chat there. There is a live link for the Google's form. And it looks like we did have another comment. Just in regards to people are parking and having picnics outside of their cars. I saw a bunch of people parked outside of a restaurant in Matthews. Yeah, it's a challenge. And, you know, Laura, do you have any comments on that?
Well, I guess we can only hope that was only their immediate household.
Yes.
Because I can appreciate wanting to have a picnic, but just got to limit it to the people that live in your household.
Yeah, I think, and you know, there's some great opportunities to get out, maybe not at the most busy times. You know, you can go for a walk or go someplace in the open air and enjoy that weather when it's not the rush hour time where there's a lot of people around.
Yeah, I think there's undoubtedly some big concerns. You know, some of the data that we shared today is really positive, and that's great. You know, seeing almost a 30% reduction in the anticipated number of deaths in phase 1 or wave 1. That's great news. You know, the data we shared about fewer hospital beds potentially needed in North Carolina, that's great news. But that doesn't mean that we can lift our restrictions. The reason we have that good news is because we are practicing social isolation. So, you know, just continue to listen to your policymakers, continue to do what they're asking, because that's what we're going to need to do to curb this.
Right.
All right. Well,
yeah, we're so appreciative of your time. Thank you for joining us. And we hope that you have a little bit of a more in-depth appreciation for some of these models and the policies that are created in response to them. And we wish you all health and safety and happiness. And we will either speak again, and if not, stay healthy.
thanks, guys. Take care.
Bye.
All right, thank you.
Thank
Thanks
you.
Thanks, Susie.